Hello and greetings. I'm back. I'm going to talk or touch on a subject where we were talking about, I was talking about my week 6 assignment on persuasive speech in reference to euthanasia and physician aided assisted suicide. This week, I'm going to also elaborate on that, and the question today is, in addition to that, we're going to talk about palliative care, end of life hospital care, and palliative medicine, and the different stages or different types of ways of euthanasia. So, back to the question at hand was, should physicians be willing to help patients to expire? With the desire to prevent longevity or constant disease, medical, moral, or infirmity of old age and gradual deterioration, weakening. We can refer that to euthanasia. Euthanasia refers to practice of intentionally ending a life in order to relieve pain and suffering. In the Netherlands, euthanasia is understood as termination of life by a doctor at the request of a patient. Euthanasia has characteristics in different ways, which they are voluntary, involuntary, and non-voluntary. First, voluntary euthanasia is legal in some countries and in the United States. Non-voluntary is illegal in all countries. However, the involuntary euthanasia is just murder. In some countries, there is a diverse of public controversy over the moral, ethical, and legal issue of euthanasia. Those who are against euthanasia may argue for sanctity of life, while proponents of euthanasia's rights emphasize alleviating suffering, body integrity, self-determination, and personal autonomy. In jurisdictions where euthanasia or assisted suicide is legal include the Netherlands, Belgium, Luxembourg, Switzerland, Estonia, Albania, and the United States of Washington, Montana, and Oregon. According to EPIC, EPEC, this capital EPEC, 1999, physicians have an obligation to relieve pain and suffering and to promote the dignity of dying patients in their care. That lies another question. Isn't that what physicians has always done? Well, on a personal note, according to Seymour, Clark, and Winslow, in 2004, morphine is used in cancer pain. My uncle is a cancer patient. He received chemotherapy and he takes morphine for pain. So after chemotherapy, he actually gets nauseous and sicker, and he don't want to eat. And by being nauseous and taking the morphine, it doesn't actually work effectively if he's throwing up the medication. So, a family member have taken him away for a couple of months. They've told me that he's on morphine. The doctor give him morphine for pain. However, there's friends that is trying to help him have given him marijuana. They said they compared the marijuana to the morphine. His results were that when he smoked the morphine, he had the marijuana, he feels better, he eats more, and he's more active. However, when he takes the morphine, it makes him sick, and he doesn't want to do anything. He's declining, and so his doctor, has informed the patient, my uncle, that he should only take one or the other. And so, I'm not going to alleviate more on the morphine in a cancer patient. But since these patients are relying on the input of physicians, psychologists, social workers, nurses, chaplains, and pharmacists, and other healthcare professionals in formulating a plan of care to relieve suffering in all areas of the patient's life. Their focus basically is on caring for the patients. Um, Palliative care is not reserved for patients in the end of life and can increase quality of life, and it helps lengthen the patient's life. In some cases, medical specialty professionals organization recommends that the patient and physicians respond to all illnesses with palliative care and not with a therapy directed at the disease. Okay. The American Society of Clinical Oncology has indicators of a patient who should receive palliative care but not any cancer directed therapy. One, American Society of Clinical Oncology. Patients has low performance. They believe that patients has low performance status, correspondence with limited ability to care for oneself, and that the patient has received no benefits from prior evidence-based treatment, and that the patient is ineligible to participate in any appropriate clinical trial, and that the physician sees no strong evidence that treatment will be effective. So I believe that's when hospice care comes in. Hospice care, patients with restrictions to disease or diagnosis, these patients will be given medical or Medicare hospice benefits. However, it requires two doctors to certify that a patient has less than 6 months to live. And if you want more information on the Center of Advanced Palliative Care, you can look up at www.capc.org. And in the American Board of Hospice and Palliative Medicine, you can search that at www.aahpm.org. Hospital care or hospice care is the only Medicare benefit that includes pharmaceutical, medical equipment, 24 hours a day, 7 days a week, access care and support for loved ones following a death. Hospice care is also available to people in home-like hospice residents, nursing home, and assisted living facilities, veteran facilities, hospitals, and prisons. But the hospital palliative care program today care for terminal patients as well as hospice patients. And I just want to add, on another personal note, how the way in which my sister had was in the hospital when she had pulmonary embolism and she fainted, and they put her in a coma. So when we got to the other state where she was in the hospital, they kept her in the coma. So we watched her a whole week. That whole week she was not responding. She was not there. Suhowever, when the nurse went to like clean her up or check the machines, the IVs, such, she would go into a cold. Well, they have to come and revive her because just with moving her. I just brought that up because when she coded a few times, in addition to being in that coma, in that state for 10 days, they had to, trying to revive her because the state, she was dying. And so they decided, a family member of the children decided that, agree that was just, she was gone. So, back to palliative care, I'm sorry. Usually palliative care patients concerned with pain, fears for the future, loss of independence, and worries about the family and being a burden. And denying an individual and their support system an opportunity to explore their psychological or spiritual concerns is just as harmful as facing them or forcing them to deal with issues they either don't have or choose not to deal with. There are 5 principles method of addressing patient anxiety in palliative care settings. There are counseling, visualization, cognitive methods, drug therapy, and relaxation therapy. So, in acceptance, physicians practicing palliative care do not always receive support for their work to reduce for patients, family members, health professionals, or other social peers for their work to reduce suffering and follow the patient's wishes for the end of life care. More than half physicians in one survey that a patient's family member, another physician, or another healthcare professional has characterized their work as being euthanasia, murder, or killing during the last 5 years. Well, I'm going to end my speech there, and I hope you enjoyed the speech and hope of doing well. I hope I did. And, and I really appreciate you guiding me and giving me the information and helping me hopefully become a better speaker. Thank you. Take care. Bye bye.